Hello, I'm Nick Turner. On behalf of my co-authors, it's a pleasure to present the primary results of the cTRAK-TN trial. Here are my disclosures. Most patients who present with triple-negative breast cancer are cured by current treatment, and we need improved ways of selecting who will relapse to focus escalation of adjuvant therapies to those patients. Detection of circulating tumor DNA or ctDNA in triple-negative patients who've completed primary treatment is highly predictive for relapse in retrospective studies. And so we designed this multi-center phase 2 study to pilot the prospective use of ctDNA in early-stage triple-negative patients. Early-stage triple-negative patients who'd completed surgery and adjuvant chemotherapy were enrolled into active ctDNA surveillance with ctDNA testing at baseline and 3-monthly for 12 months. Patients who are ctDNA positive were randomized double-blind between observation and continued standard follow-up or intervention. Treatment arm patients had staging, and those without metastatic disease were offered the immune checkpoint antibody pembrolizumab every 3 weeks for a year. For ctDNA testing, tumor tissue was sequenced to identify somatic mutations. Personalized digital PCR assays were designed for 1 to 2 mutations per patient and tested on a Bio-Rad digital PCR instrument. We registered 200 patients with the aim of getting 150 patients into ctDNA surveillance, and we assumed that 30% would be ctDNA positive within 12 months. And of those, we anticipated that 20% would have metastatic disease on staging scans. The treatment and observation groups were not statistically powered for formal comparison, but to describe the rates of clearance of ctDNA. I highlight 3 trial adjustments made to the study while it was recruiting. ctDNA testing was suspended during the first COVID-19 wave, and active ctDNA surveillance was therefore extended to 15 or 18-month time points to replace missed samples. Entry criteria initially allowed patients to enter up to 6 weeks after adjuvant radiotherapy, but this allowed patients to enter later than anticipated, and these were subsequently amended to mandate entry within 6 weeks of surgery after neoadjuvant chemotherapy or before the 3rd cycle of adjuvant chemotherapy after primary surgery, and this amendment was implemented after 154 patients were recruited. And finally, after advice of the Independent Data Monitoring Committee, the observation group was closed later on in the trial after all patients were recruited, with all subsequent ctDNA positive patients allocated to pembrolizumab. Co-primary endpoints were the rates of ctDNA detection 12 or 24 months after starting surveillance, and the rates of sustained ctDNA clearance on the pembrolizumab group, defined as the absence of detectable ctDNA 6 months after starting treatment or not having recurred. 208 patients were registered from 16 recruiting centers. 77% were high risk, 131 were defined as moderate risk. High risk for patients who had neoadjuvant chemotherapy with residual disease in an axillary lymph node, and for primary surgery was a tumor size greater than 50 millimeters and node positive or more than 4 nodes. Moderate risk was everyone else recruited into the trial. Neoadjuvant chemotherapy had to have residual disease, and after primary surgery, they had to have a tumor size of greater than 20 millimeters or an involved lymph node. And of the 208 patients registered, 161 entered ctDNA surveillance. Here are the surgery and treatment details. As you would expect, high-risk patients had larger tumors and were much more likely to be node positive. Just under 40% of patients had neoadjuvant chemotherapy only, 28% adjuvant chemotherapy only, and 25% had both neoadjuvant chemotherapy and adjuvant capecitabine. At a median follow-up of 20.4 months, all patients had completed active surveillance. The proportion ctDNA positive by the 12-month time point was 27.3%. Looking at the time to ctDNA positivity below, you can see that it differs substantially between moderate and high-risk patients. In moderate risk patients, 11.8% were ctDNA positive at 12 months, but in high risk patients, this was 55.7%. 45 patients were ctDNA positive and entered the therapeutic trial. 11 allocated to observation, 32 allocated to pembrolizumab, including one patient who was initially randomized to observation. The rate of overt metastatic disease on staging at the time of ctDNA detection was 71.9%, substantially higher than we anticipated. 9 patients were ctDNA positive and staging negative. 4 of these declined treatment, principally due to concerns about treatment during the pandemic, and 5 started treatment with pembrolizumab. I show you the ctDNA trajectories in these 5 patients. 4 have subsequently relapsed, 1 remains on treatment, and no patients had sustained ctDNA clearance. But I do highlight the patient in pink, who after an interruption for an immune adverse event had sustained ctDNA suppression on treatment. For completeness here, I show you the safety adverse events on the trial. 14 patients were enrolled into the observation group. The lead time to relapse was 4.1 months in this group, which is shorter than prior retrospective studies, likely due to reflecting the high-risk patient population recruited. I show you the ctDNA trajectories in the observation group here. 4 patients at times have become ctDNA negative, reflecting low levels of ctDNA at or below the level of detection of the assays, and this then is reflected in ctDNA clearance in 21.4% of the patients. There was great variability in the ctDNA trajectories, and I illustrate that by highlighting 2 patients, one in green who over a 3-month period had over a 100-fold rise in their ctDNA level, and one in pink who over the same period had stability. And we will clearly need to understand the biological basis for this great variability in the future. And finally, we analyzed the factors that contributed to the high metastatic rate staging the ctDNA positive patients. On the left, to take account of the variability of when patients entered the study, we reanalyzed ctDNA results in calendar windows as the time from surgery for neoadjuvant chemotherapy patients, or the time from the last cycle of adjuvant chemotherapy for primary surgery patients. In blues, the rate of ctDNA positivity higher in the 0-month time point at 11% and then subsequently falls. And in red are the rates of overt metastatic disease, which were very high early on before then subsequently falling. Next, we estimated the proportion of patients who had metastatic disease already on their CT scans when they enrolled for baseline ctDNA assessment. 1.4% of moderate risk patients had undiagnosed metastatic disease, but 28.5% of high-risk patients already had metastatic disease at enrollment. And then finally, in the latter part of the study, ctDNA testing commenced 3 months into capecitabine at roughly the halfway point. And at this point, 18.2% of patients were already ctDNA positive 3 months before they were scheduled to end capecitabine. So in conclusion, the cTRAK-TN trial is, to our knowledge, the first prospective study to assess the proof of principle of whether ctDNA assays can guide therapy in triple-negative breast cancer. At enrollment, the patient had a relatively high rate of undiagnosed metastatic disease when imaged, especially high-risk patients. And relatively few patients commenced pembrolizumab, precluding an assessment of potential activity. Our findings have implications for future trial design. Most importantly, to start ctDNA testing early and likely to employ more sensitive ctDNA assays that track multiple variants. Potentially, more frequent testing is advisable in the 0 to 6 month time points, given the rapidity of disease evolution. and consider starting ctDNA surveillance during adjuvant capecitabine, and regrettably, the highest risk patients may not be appropriate for ctDNA surveillance. I offer very grateful thanks to patients and their families who entered into the study, and I thank very much the bodies that have funded this study. Thank you very much.